carrying on, I would like to now talk a little bit more about how we diagnose patients and what have we. And Ahmed, patients come to you, they have HCC, biopsy, no biopsy?
Yeah, so that's a very important question, and
I always ask only important questions.
Right. So for us as medical oncologists, and we all were trained that way, no meet, no treat. So we're used to getting biopsies. The old era, 15, 20 years ago, those patients were presenting with child-pugh C, coagulopathy, severe ascites. So the biopsy risk was very high. So in my practice, and many of us now do this, if it is safe to obtain a biopsy in this era of immune profiling and molecular profiling, we always require it, especially in cases where you have no evidence of cirrhosis, which is biopsy in that case is really mandated.
Fair enough. You bring very important points we're going to come back to. But before we go there, Anthony, imaging, what's your favorite?
Well, the importance about imaging is that it's multi-phase imaging. Whether it's CT scan or MRI, the multiple phases are important because the reality is that, especially in the community, we still diagnose HCC very commonly by imaging. So we need to see the arterial enhancement in the arterial phase and then the washout in the venous or delayed phases. This is a critical component because we see many patients come in with single-phase scans and arbitrary diagnoses are made that way. Now, I do agree that to advance the field, obtaining tissue is important to allow us to do the appropriate research, especially as we have more options of systemic therapy. But in reality, in the community, the radiologic diagnosis is certainly an acceptable approach as well.
Fair enough. And to that extent, the radiologic approach now with the LI-RAD, how much do you practice that in your practice, Catherine?
So we very much use the LI-RADS criteria. Okay. And when I'm deciding on a biopsy, I really too think about the stage of cancer that the patient is in. Sure. Needle track seeding and bleeding from the biopsy is rare, but it's real. And if I have a patient that may potentially be curative through resection or a transplant, I'm a little more reticent to do a biopsy because of that risk, where we don't want to spread the tumor that could then prevent a curative treatment. I agree getting a biopsy to advance the field and to help with molecular profiling with more advanced disease might be helpful. But in the early stage disease, LI-RADS is very, very useful. I have a lot of patients that come in from the community for a consult, and I always prefer to discuss them in a multidisciplinary tumor board before we think about a biopsy at that point.
Fair enough. And Peter, to go back to the next generation sequencing that already both Ahmed and Anthony brought it up, have you seen any value to it? Did you identify any time a certain genetic alteration that, whoa, that's interesting?
I have to say that we have become somewhat enamored with performing next-generation sequencing in many of our patients that we present at our multidisciplinary team meetings. I will also say that of about 220 some unique patients we see every year, we very rarely come up with druggable, actionable information from this. I can recall notably a patient who turned out to have MSI, microsatellite instability, who actually benefited tremendously from an IO treatment when one might not have thought that that would be the case. But I can't name you many other examples of patients where we've done NGS and ended up finding a track that we could treat and effectively prolong life in a dramatic way.
It's amazing that we're hearing here like very, very essential components. And if anything, to re-summarize it is, number one is, I like the way Dr. Kasib said it, like, no meat, no treat. We need to look at tissue. It's very critical. And this is especially from the perspective of medical oncology. However, I also agree with Dr. Fernat. If anything, we have to look at the whole spectrum. Patients with very early disease, i.e. a potential for curability. For example, somebody with a disease that is transplantable or surgically resected or RFA, I can totally understand why a biopsy is not necessarily required before we move on to this, because of the risk that Dr. Fournette, even though I agree with her, it's extremely low, 0.00003 for seeding, but nonetheless, it can still happen. And on the other hand, the transplant community would prefer that patient is really not altered in regard to any biopsies or what have we. That's totally fine. However, when we come to the patients with metastatic disease, advanced disease, where curability is not anymore the point, but rather to kind of ensure we have control of the cancer. And now with the advent of therapies that we're going to talk about endlessly, by all means, a biopsy is needed. And I totally agree with Dr. Koueri, is that not only the biopsy is needed for the confirmation of the diagnosis, but also it's required so it can give the opportunity for the further analysis and germline testing. Interestingly, if you ask any of us today, is it really critical that we have germline testing for HCC patient? We'll say probably based on the therapy we have, it's not necessary. But interesting, if we don't do it, we will never know if it's necessary or not. So it's very critical that we continue to do this. As we heard from Dr. Ghulam, interestingly, the patient that he referred to with the MSI high in HCC, this week alone, this is the second patient I hear about with an MSI high with HCC. And for example, FGF19 patients with a mutation of FGF19 and HCC, they definitely exist as well. So definitely you have to make sure that we obtain the tissue, confirm the diagnosis, and understandably, especially in the metastatic setting, we need this to make sure we give the right therapy, because at least based on some data, 10 to 20% of the patients might have a combined HCC and cholangiocarcinoma. And it's very important to delineate that. And then on top of this, as we heard, the next generation sequencing will be very critical to either guide patients when need for other therapy beside what we're going to talk about today. And number two, of course, for the research purposes that will help us understand better where we're coming or moving with in regard to that field.